بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على رسول الكريم أما بعد Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Human Kashavarzi. Welcome again to our course on mental health within an Islamic context. I am your course instructor and facilitator, and we are in week 3 talking about roles and responsibilities and boundaries, competencies for working with American Muslims in mental health care settings. So this lecture is predominantly focused on addressing roles, responsibilities, and boundaries. I wanted to just set a framework or begin some important competencies and discussions for you all early in the course on to be able to think straight and to be able to wrap your minds around working with mental health and in mental health settings. So as chaplains, you play a very important role in mental health because there's a huge public health care gap, or a SAMHSA, or the behavioral health research, public health research usually says it's uses the terminologies. It's behavioral health care disparities for particular specialized populations, and the specialized population here is Muslim populations. The American Muslim population, there's a rough estimates of 3 million to 10 million American Muslims, and there's a very small ratio of Muslim mental health care providers, especially those Muslim mental health care providers that cater to Muslim mental health. Therefore, chaplains become very, very important in being able to be available and accessible to be able to either direct people to mental health settings or at least begin to provide some preliminary kind of relief. And of course, the strategies and techniques and and sort of more hands-on trainings we will offer in the 2-week course in the summertime, which I hope that everybody will in this course will sign up for, because it'll be a lot of role play, hands-on. We're going from theory to application. So I want to start off by saying that one must have a framework for working within working in faith-based settings. Essentially what I mean by that is a faith-based healer within healthcare settings, because there's sort of this collide between your faith and then the context that you're offering treatment within. I mean, where chaplaincy really emerged from here in the US is that, after the separation of church and state and how society is structured based upon secular lines, there had to be a way that faith-based healers would be able to work within a secular system or setting. It's really a community worker. It's the pastor or rabbi or imam or whatnot would emerge from the church and go out to the community and work much more in a communal setting, right? They would kind of go out to people and bring faith to them, because secular society didn't root or embed religion within the fabric of everyday society and in most settings. So there's this sort of interesting kind of dilemma that you face between being a faith-based healer in a healthcare and working within healthcare settings, where a faith-based healer really conceptualizes the world from a faith-based perspective, and in the secular world, in healthcare settings where it's predominantly secularly based, they don't conceptualize based upon a faith-based perspective. And there's that sort of unique challenge of being able to bring faith to a secular setting. And so in doing so, you have to be able to have a framework for how you're going to address people in these sorts of settings. So for example, you might believe that as a Muslim, you have a responsibility for da'wah and to impart the message and to fulfill the obligation of the Prophet Muhammad ﷺ by by doing tabligh of the risala, of spreading the deen. But then you have this sort of ethical dilemma in healthcare settings where that's not very welcome. Proselytizing, for example, is an ethical restriction. So how do you reconcile that dilemma where you feel like you might need to proselytize a patient versus an ethical, restriction on doing so? My suggestion, usually the way that I work, because I too see myself as a faith-based kind of healer, so to speak, though I use psychological mechanisms rather than come from a faith-based perspective solely and only. The way that I conceptualize this as a Muslim practitioner is that I say that I work within the framework of the faith-based tradition of that individual, right? So my responsibility of proselytizing is restricted. Da'wah is not only in the form of verbally saying to somebody that you should become Muslim or what their faith should be, or questioning their faith, but rather me as a Muslim in my conduct and being able to provide help and relief might be able to potentially inspire them to be able to explore religion or Islam on their own prerogative if they wanted to. But even if they didn't, my presence was sufficient to be able to say that you've interacted with a Muslim in this sort of setting as well. Additionally, you don't want to conceptualize your patients as suffering, you're suffering through your own faith-based tradition. This especially comes up when you're doing interfaith, because as a faith-based healer, particularly as a chaplain, you know better than myself, in many healthcare settings, you're going to be working with Christians and Jews and whatnot. You might have an internal conceptualization of what's going on with the individual, but you might not necessarily want to verbalize or project or put that on your client because or the person that's sitting across from you, because that person is maybe not ready for that. So you have to sort of have a framework of how you're going to be able to work with that. Recognizing one's personal boundaries, right? So saying to yourself, hey, I have deep religious convictions around particular things, and I don't think I can comfortably work with those particular things. And I would challenge you to broaden those horizons, but you also have to have that self-recognition to be able to say that I can or cannot work with particular kinds of issues. For example, whether it's homosexuality, gender identity disorders kind of stuff. What's your framework for working with that, or being able to be helpful to an individual? And as a mental health provider, for example, when I work with a person who's homosexual, for example, I don't see my job as necessarily changing that lifestyle or conviction, but rather, and maybe for me it's a little bit easier as a mental health provider, is I'm working with the distress and psychological distress that they're coming in with, and I want to provide some relief from that distress. And what they do with their lifestyles and what choices they make is really their own business to choose. So that's kind of this figuring out, how do I work within a healthcare setting, being a faith-based healer, and being true to my religious convictions, but yet not overstepping my ethical boundaries in healthcare settings. Some of the things that are very important to be aware of is your countertransference. When the chaplain experiences feelings towards a patient, this could be positive or negative, right? So, in working with a homosexual client, for example, are you disgusted? Are you feeling very uncomfortable? In working with somebody of a different faith-based tradition, do you feel an internal anxiety and guilt of having to proselytize them, and you feel guilt for not doing so? And that's coming up and interfering in your ability to be really present with that patient or that client. A chaplain actually might be unaware of the countertransferences that they're having towards a patient, and they can actually lose objectivity. You might find that it's not always in your immediate awareness, right? You might, for example, make it, give them less time. You might delay appointments with them. You might say that you're too busy with meeting them. Another opposite scenario might be positive, meaning that you're so curious about a particular client that it reminds you of yourself, and you're so engaged that you end up, spending a little bit more time with that patient, for example. Another instance might be that you're, asking or questions or directing the dialogue in a direction that's more about your own personal curiosities than it is about the well-being of the patient. For example, a person, talks about how they, I've had a client, for example, that comes from African origins, and their family is accustomed to having polygamous marriages. So you end up having this dialogue about polygamy and their conceptions and what their experience was like, and what their opinions and views are. And it ends up becoming just a sort of side dialogue, and it becomes counterproductive to that sort of pastoral, faith-based, mental health, counseling, whatever you want to call it, faith-based counseling encounter. Other things might be irritation, right? As we talked about, becoming irritated by a patient based upon your internal biases or your judgment of them, etc. This is what we call countertransference. So as a chaplain, I think you really need to figure out what your scope of practice is. I think that's very important. A lot of chaplains that I've worked with at Hartford and beyond sometimes struggle with a framework as to how they're going to work in healthcare settings, right? How to deal with and manage sort of certain ethical dilemmas, but also having a framework for how they're going to work. You're going to have sort of a religious, spiritual framework, I imagine, as to how you work with your patients, work in your particular setting. Do you do program development? Is that part of what you do? What is the scope of your practice? Do you do this or do you not do this? In some healthcare settings or in some workplace settings, you'll find people have their own understanding of what a chaplain is, and then you have an understanding of what a chaplain is. But it's your responsibility to educate and work with that setting to figure out what your roles and responsibilities are going to be. It can't be that the chaplain is called in for really just about any miscellaneous item. Program development, sometimes they're called for ethical dilemmas, sometimes they're called for religious consults, for counseling, to administer social services, maybe administrative duties. I think you need to be able to outline and say, this is what a chaplain does, this is what a chaplain does not do. And for some of you, and for chaplaincy, it might not be so clean cut because of the communal nature of your profession, as well as the newness and novelty of Islamic chaplaincy as well. So do you administer social services? Are you a counselor? Do you do counseling? Do you not do counseling? You want to be able to make it clear. You don't do mental health-based counseling. You do faith-based counseling. What does faith-based counseling mean? And you also want to educate people that you work with. When they see you, like a patient in a healthcare setting or mental health setting, they say, can you help me with this problem? And you can say, here's what I can help you with, here's what I can't help you with. Do you do marital counseling or do you not do marital counseling? Do you do student counseling, career counseling, personal counseling? The other questions are, when do you serve, let's start with, who do you serve? Do you serve students, inmates, military, patients, men, women, children? These are based upon your context and setting and your training. You might be trained to serve particular individuals. And based upon your own expertise, you may or may not be able to serve certain people. So you might not be able to work with children for a particular reason, you might have discomforts with working with the opposite gender. You need to make clear whom you serve and whom you don't serve, and have a good reason as to why you serve them and why you don't serve them. Another question is, when do you serve? Do you serve on the clock? Some people see a chaplain as being on the clock, like imams. You can call them for a crisis emergency at any time, and they're supposed to make themselves available. Do you have office hours? Do you provide emergency coverage? What do you do? And what's your pitch about things that you don't do. If you say you don't do crisis cases or emergency, is there an outlet that you have for that? You say, here's a number you can call, here's a person you can work with. So you need to have this sort of sense of when you serve as well. You know, in talking about boundaries from the Islamic tradition is very important. Unfortunately, in our community, sometimes we don't have clear sets of boundaries, roles, and responsibilities. And that makes way for a lot of problems and false expectations. If the board of directors expects the Imam to do a particular thing, but the Imam doesn't want to do that or is not within their scope of practice, then when the time comes, they're going to have this dilemma. They're going to say, oh, well, who's going to do this, right? So it's very important to have things clearly outlined, and there's a had and hudud, right? The concept of had. Allah describes rules of fasting, what you can and can't do in fasting. Allah describes, rules of gender interaction. Hijab is an example of gender boundaries. All of these things have particular prescriptions, parameters, things that you can and can't do. And I think it's very important for you to have this framework and scope of practice to say, here's what I can and cannot do in these particular kinds of settings. And I cannot overstep my boundaries, say, into mental health counseling or into fatwa, for example, if you're not trained as a faqih. So you want to be able to clarify to people what it is that you are, especially because Muslim chaplains can vary in degrees as to what they do, right? So there are some actually who are, licensed clinical professional counselors, and then there are some that are pastoral counselors. There are some that have none of that training. And then there are some that are, scholars of the tradition as well, Islamic tradition, or even fuqaha, for example. And it might really vary. So you have to be able to really educate and tell people what it is that you can and cannot do. In addition to the Islamic boundaries, you also have professional boundaries, right? You are a professional. You do have a board. You have a code of ethics, and you have professional boundaries. And professional boundaries, in psychology, here's a quote. It's parameters that describes the limits of a fiduciary relationship in which one person, a patient, entrusts their welfare for another, the counselor or mental health professional. And in this case, where a fee is provided for the provision of service. But that doesn't necessarily have to be the case that there's a fee. But there are parameters, and that there's a sense of trust, and we call this amana in the Islamic tradition. Al-majalusu bil-amana, that meetings are a trust. And the purpose of professional boundaries is to prevent exploiting the inherent power differential. Of course, you have somebody comes to you in a state of vulnerability. That's why it's so, أشد الناس عذابا يوم القيامة عالما لم ينفعه الله بعلمه. That the person who will be punished the most on Yawm al-Qiyamah, there's a hadith of the Prophet ﷺ, will be that scholar whom Allah did not privilege him or give him tawfiq to be able to act upon that knowledge. So to exploit people, for example, that's a breach of power and boundaries. To prevent the provider from getting into trouble legally, professionally, emotionally. Who does this apply to? It applies to physicians, psychologists, therapists, teachers, preachers, chaplains, imams. It applies to chaplains as well. And I think it's very important for you all to know the rights and responsibilities that apply to you legally. So, for example, are you a mandated reporter or are you not? In most cases, clergy and chaplains are mandated reporters, but it's also very important for you to know that different states have different rules and regulations regarding particular confidentiality rules that are afforded to clergy as privileges. So in certain cases, you are allowed to keep the confidentiality of a person, and that can trump and override the mandated reporting policy, actually. And you have to look at your state state differences, and if you're interested, I can email you a document, and in fact, I might be able to post it up on our documents list in the module for you to be able to view across states whether this applies to you or not. Where do you serve? Do you serve at your home, your office? Do you sit in the hall and serve? Is that acceptable or is that not acceptable? Is that within your scope of practice? Do you use the internet, the phone? I have a policy where I don't use my phone. I let people know in a nice way. It doesn't have to be confrontational. Sometimes people have issues with being able to say things. They want to be helpful, but they end up doing more harm than good in trying to be helpful. So you try to, serve everybody on the phone, but your phone is ringing off the hook. You can't meet everybody's needs, and then people are upset and they expect crisis management from you that you can't provide. Or your family's upset with you and you can't take care of your own needs. So what I say on the phone, for example, I'll pick up the phone and say, Assalamu alaikum. If they go on too long, they'll say, hey, I want to be very respectful of your time and this issue. I want to afford it so much respect that I want to be able to schedule an appointment with you so that we can take this very seriously. I don't think I'm in a position at this moment to, at this very moment to be able to give you the full right of, and your responsibility is being able to attend to this problem and really listen to your case thoroughly. So let's set up an appointment. How do you feel about that? Most times people are very open to that and they're very accepting of that. So I suggest you have sort of a script or, an internal mechanism to figure out how you're going to work and whom you're going to work with. The how. You're going to have to know your limits and responsibilities, obviously. Are you more supportive versus prescriptive, right? Are you going to, take which kind of framework are you using? Are you using a pastoral clinical counselor, pastoral counseling, faith-based counseling, more mental health counseling kind of framework or perspective in your approach? Are you prescriptive in the sense that if you're more of a religious authority and can you invoke religious authority, which I actually suggest that you do because you do have that authority as a chaplain, especially when you've been certified by a religious kind of body within the Muslim community. You're a Muslim leader. You're a leader of our ummah, of the congregation. So people come to you for answers, and if you don't know an answer, then you can look it up, and that's part of the job, is for you to also be able to be prescriptive as well. Let's take a look at where one role begins and one role ends. This is just my suggestion of a framework to be able to work within this domain. And I wanted to, basically in outlining this, I want to basically set some parameters for what a pastoral faith-based counselor or a chaplain can do and where their boundary ends and where mental health counseling begins. Kind of set maybe a broad understanding of differences between the two roles. And a useful strategy for this is that, Imam al-Ghazali, for example, had laid this quote out in his Ihya, which I really liked. But I personally prescribe and I like a collaborative conceptualization. This is the overlapping, right? If we have a Venn diagram with an overlapping area, both people are going to form a relationship. Both people are going to try to help introspect. Both people are going to try to help uncover psychological, behavioral, and spiritual processes to help that patient or client conceptualize their own suffering, to understand what's going on. And once that understanding is there, then we can begin to understand where to take them or what to do, whether that includes a referral or whether we can tell them, here's what I can do for your problem as a faith-based healer, and here's what I can't do. Here's what I can do for you as a mental health counselor. And Imam al-Ghazali says, he cites this hadith, إِذَا أَرَادَ اللَّهُ بِعَبْدِهِ خَيْرًا بَصَّرَهُ بِعُيُوبِ نَفْسِهِ. That if Allah wants good for a believer, then for his abd, his servant, then He will give him insight or awareness of his own faults, of his nafs. And he says that there are two main modalities of being able to do this. One is through the traditional tasawwuf perspective. You go to a sheikh and you hand yourself over, and they supervise you and help form you and discipline you. And another perspective, which is very relevant to us, is that you go to somebody, aliman bi asrari hadha al-amr, somebody who's very educated in these sorts of matters, whether it's religion or in a mental health context, knows about the psychopathology and mental health, and take their company and form this sort of relationship with them, and they will help introspect ليلاحظ أحواله وينبهه على عيوبه, and that he will help you uncover your pathologies and your weaknesses and your struggle. So the role of the counselor, for me, what I see is that for both people is that they're this sort of collaborative peer, and more so for the clinical counselor, for the mental health provider, is that they are not an authority, but rather they help, and this is my framework. I don't have the authority to tell you what the Islamic tradition is or what you should believe and not believe, but what I can do is provide suggestions to you because you say you're a Muslim and you subscribe to the Islamic tradition. So I might say to you, you believe as a Muslim that God is good. Yes, I do. And that there's good in suffering. For example, perhaps you hate for something, but actually it has khair in it for you. You believe that as a Muslim. Yes, I do. But at the same time, you're telling me that you feel that you're being punished for this. How do you reconcile that? So I might help them make suggestions for the way that they might think about something, but I'm not really inserting a new belief, but rather it's a belief that they already subscribe to as a Muslim, and I'm offering a suggestion for a different psychological window to be able to see that perspective, to be able to induce change. What else does a clinical counselor do? They're an expert on psychological distress and its treatment, not theology. This is unique to the clinical mental health counselor. They can examine and assess based upon their understanding of relational patterns and psychopathology. Sometimes when you see somebody, you might be missing an underlying psychological or mental illness that might not be visible. So you might prescribe a religious intervention, but actually miss the fact that they're having really an underlying psychological illness underneath that. The clinical counselor relies on research and behavioral science. They can integrate and incorporate religious concepts as suggestions, as I mentioned, within the frame of reference of the client, but not as an authority or injunctions. I can't say, no, that's not the Islamic perspective, that's incorrect, I want you to, this is what it is. But what I can do is I can direct them to, say, a chaplain. Hey, why don't you set up an appointment with your chaplain to talk about this and get some education as to whether Islam really does view this issue from this perspective or not. And just as a cultural consideration, even in mental health settings, Muslims seem to really value a directive approach. They do want to have some answers, like, help me understand what's going on and what might be the avenue to be able to get some relief. Some limitations on pastoral counseling. Addressing psychopathology with religious interventions might actually be very, very harmful to a person. Though many clergy and chaplains might have a lot of experience, their interventions might not be informed by behavioral science or research, so they might be getting it wrong, even though they have a lot of experience. A lot of especially severe psychological distress requires long-term care, where chaplains may not have that luxury of time. And due to psychological distress being an invisible illness, many might not be able to see it and might misdiagnose it as a spiritual problem, such as it's a jinn or evil eye or something like that, though I don't doubt that that's a possibility, we might overdiagnose those and miss the underlying psychological distress underneath it. And then the pastoral counselor or the chaplain has a more authoritative perspective. They can be more directive. They can be more teachy and coachy as well. Not preachy, because I don't like preachy, but they have religious weight. And they can provide spiritual relief and insights and sort of a spiritual care and presence that a mental health counselor cannot provide. So that's why this collaboration is really important. They might be able to provide education on fiqh issues, especially in a hospital, end-of-life care, abortion, no abortion. Is this allowed? Is this not allowed? You might provide education to a client, even though you might not give them a fatwa, you might give them the range of education, and then they can either consult a mufti or they can adopt a position based upon the education that you've given them. You can use more traditional healing methodologies, such as ruqya and du'as and prayer, etc., that mental health providers might not have any insight about. So this, what I'm talking about is that definitely this unification, this partnership and collaborative care is important because, in fact, 90% of Americans conceptualize their pathologies through a religious perspective, a spiritual framework. And this is especially so for Muslims. Muslim attitudes towards psychological distress is that they see it through a religious perspective. And as I mentioned, there's a ratio gap between available Muslim mental health providers and patients out there due to discrimination, etc. Due to mistrust of providers, Muslims might not be willing to go to, non-Muslim providers. They might fear treatment, racism, language barriers, religion, communication, etc. So it becomes much more imperative for chaplains to fill this gap of emergency relief. In fact, if we look at this sort of behavioral healthcare disparities chart, we can see that where a person, frequency of need, where a person tends to get their care is initially they try self-care, then they work within the informal community care before they go to mental health services. So before they go to a mental health provider, they're going to imams and chaplains and pastors and etc. So you're going to be the first line of defense, and that's why I call this actually first responders. And at Khalil Center, actually, we have a first responders training for imams now, which we've labeled it as a first responders training because you're the first person that a mental health, that a person who has mental health disability comes and sees, and it becomes that much more important for collaboration and for you to direct them to the appropriate source. So the role of the imam can be a gatekeeper as well as a director. They can actually help facilitate the connection to mental health providers. And we find that majority of people are actually, data shows us that people are going to imams. And that the majority of these imams have very, very few of them have any exposure to mental health training whatsoever. In fact, a Muslim study in NYC finds that the majority of Muslims believe that their imams are actually counselors. And this is problematic because many of these imams have absolutely no training in psychological distress or counseling or whatnot. They might study theology and it's oftentimes textual unless they have good internship experiences or they've studied additionally themselves. They might not have the capacity or resources to be able to engage these individuals at the level of care that they need. So Muslims are coming to you expecting this, and this is where you design your scope of practice. Just because Muslims are coming to you doesn't mean you have the capacity to be able to treat all of these people if you don't have the appropriate credentialing or knowledge base to do so. Barriers for service. Muslims might not come to psychological treatment or mental health treatment because those who identify with Islamic values want their issues addressed from an Islamic perspective. So that's why they're more likely to go to a Muslim. And this is where you intervene, this collaborative care. If there's no Muslim, you might link them to a culturally sensitive and accepting psychologist or mental health provider, and you provide the adjunctive spiritual care. It can be done hand in hand. You might be the liaison between finding them the appropriate care, because Muslims are more reluctant to trust healthcare providers because of the fear of them not respecting their Islamic values. Many American Muslims believe that their problems are due to spiritual, so this is very important for chaplains to be involved. Many attribute it to jinns and evil eyes and spiritual causes, and they seek out traditional treatment. So and this is sort of preaching to the choir and giving justification for your perspective, majority of people cope through for psychological distress through prayer. In fact, many people who are physically sick rely on prayer and exercise and rituals and traditional healers, and these are non-Muslims, by the way. In medical intervention, people want more integration of religion. 80% of mentally ill people use religious coping. So it's very important for spirituality to be a part of this process, part and parcel, but they cannot be to the exclusion of one or the other. And, national polls find that, and this is good data, I want you to sort of memorize this data and spit it off in your healthcare settings as to the justification and funding for chaplains, is that 48% of patients would like their physicians to pray with them. 64% believe that physicians should pray with their patients if patients ask. And assigning a spiritual meaning to life after discharge for physical disability actually decreases relapse. Especially in mental health settings, people want to talk about spirituality and religion. There's evidence to show that spiritual coping enhances a person's psychological functioning. And this is a study on Muslims. Independently, as a coping mechanism, it's very powerful as a healing mechanism. So my final conclusion for this is the justification for the understanding the roles and scope of your practice and having a framework, do's and and do nots, a hudud for yourself, the boundaries. And then knowing your boundaries will also help you develop this appreciation for those who exist outside of your boundaries and have particular expertise. And you want to marry the two, and you want to have the healthy collaborative relationship. And proof is in the pudding. Khalil Center in Chicago is very successful in doing that. We have imams and Islamic centers in our community that are among the primary referral sources for our psychological treatment center. And we collaborate, and we get consent forms filled out so we can collaborate and continue to discuss and work alongside their imams for them to provide spiritual relief while we provide psychological relief. So ultimately, play a supportive role, identify your allies and collaborative peers, be a liaison to getting the people in the heart in the right place, and have a culturally sensitive approach. And that concludes today's lecture. And I hope that this was beneficial to you. وآخر دعوانا الحمد لله رب العالمين.